This conference will now be recorded.
So today we are going to discuss the talk on the male infertility, which is the recent this October 2020 talk. But I have included this 2013 talk also of male infertility because previously this was the only source to study regarding the male infertility, and now they have given the recent advances in this male infertility in this 2020 talk. So what I have tried to do, I have tried to combine the both talks, so it will be a useful information. It will be a compiled information because nowhere elsewhere you will find the information regarding male infertility. So I have compiled the both two talks together. Okay. So see, the first talk, 2013 talk, it was basically what you are expected to do from that talk is regarding the causes of the male infertility and how to assess the male infertility. That is the first thing that you should do from the 2013 talk. Well, this 2020 talk is about more about all these recent tests, okay, that is DNA fragmentation and genetic testing. So they have given in detail regarding these tests, okay. So the questions which will usually come on this male infertility, these are regarding the semen parameters. Another thing is when you are going to do ICSI, when you are going to do hormonal evaluation, and when you are going to do karyotype. So these are the basic things that you should know what to do regarding this. Okay. So first, regarding the epidemiology, 1 in 7 couples they have subfertility or difficulty in conceiving. 1 in 7 couples in UK they have difficulty in conceiving. Male factor is responsible for almost 50% of these cases. Okay, so male factor is a contributory factor in 50% of these cases, and male infertility is thought to affect 7% of all men, and it accounts for 37% cases of IVF treatments. Okay, which of the most commonly which will involve because of male fertility, it will involve ICSI. Now, how this spermatogenesis occurs? So spermatogenesis basically occurs in seminiferous tubule and germ cells. So it starts from the germ cells which are known as spermatogonia. So the first division from the spermatogonia in the seminiferous tubule in testes. So first division is by mitosis. Okay. So it will be one cell give rise to two cells. Okay. So after these two cells of spermatogonia, these are called as primary spermatocytes, and these primary spermatocytes, they undergo meiosis. So there will be two divisions. So one cell give rise to four spermatids. So this is the basic spermatogenesis. And after this spermatogenesis, then there will be a spermiogenesis. So it is called as maturation of the spermatids. Okay. So maturation of the spermatids, it is known as spermiogenesis. So these spermatids, they transform into cytoplasm free sperm, which is condensed DNA in the head, apical acrosome, and cell. Okay, so this process depends upon the FSH and testosterone. Now, what happens for spermatogenesis? So, till the process of the spermatid formation, it depends upon the FSH and testosterone, and final maturation will depend upon the luteinizing hormone, that is LH, and that is secreted by the Leydig cell. Okay, so basically, uh, LH is necessary for this maturation, while FSH is required for this basic spermatogenesis. And this entire process, it takes around 3 months. Over 50% of cases of male infertility, these are either idiopathic or unexplained. So only you can find cause in about 50% of cases. And therapeutic intervention is usually for this idiopathic male infertility is by ART. Okay, so remember that only thing treatment available for male infertility is only for hypogonadotropic hypogonadism, where you are going to give gonadotropins. You can give gonadotropins here to treat this hypogonadotrophic hypogonadism. This is the only thing where you can prescribe treatment for male infertility. Otherwise, all treatments, they are in the experimental form and they are not of proven evidence. So the basically male factor infertility treatment lies with this assisted reproductive technology. Now, the causes of male infertility, they are divided into pre-testicular, testicular, and post-testicular. So in pre-testicular causes, there are hypothalamic. So basically it is a dysfunction of HPO axis. Hypothalamic pituitary, it is or testicular axis, it is not ovarian now. So hypothalamic disease, basically it is Kalman's syndrome, and pituitary disease, they can be tumors, radiation or surgery or hyperprolactinemia. And third thing for which is responsible for pre-testicular failure is anabolic steroids. Okay, ingestion of anabolic steroids by males and glucocorticoid excess or hyper or hypothyroidism. So these are the causes for pre-testicular failure. Then testicular causes are, they are again divided into congenital and acquired causes. So congenital causes are genetic, chromosomal causes like Klinefelter syndrome, bichromosome deletions, Noonan syndrome, that is also known as male Turner syndrome, and cryptorchidism. While in acquired causes, there may be injury or infection like orchitis, torsion, trauma, varicocele, systemic diseases like renal failure or liver failure, chemotherapy, radiotherapy, testicular tumors, and again idiopathy. So these are the testicular causes. And post-testicular causes, these are mostly obstructive causes. So in that obstructive causes, they are again divided into congenital and acquired. So congenital causes for post-testicular failure are cystic fibrosis or bilateral congenital absence of vas deferens, Young syndrome, that means absent cilia or cilia, this thing. Acquired causes are vasectomy, infection, or iatrogenic vas injury. Other causes, they can be disorders of sperm function or motility like immotile cilia syndrome, maturation defects, immunological infertility, or globozoospermia. While sexual dysfunction depends upon the erectile or ejaculatory dysfunction, diabetes mellitus, multiple sclerosis, any spinal cord injuries or pelvic injuries. So these are the causes for this male infertility. So now what are the environmental factors which are affecting this male infertility? So first is age. Now this environmental factor, those are given in both talks, okay? But go with this recent talk, go with the information of recent talk, because these factors are explained in both 2013 and 2020 talk also, 2020 talk also. So go with the 2020 because this is the most recent one. So according to age, so paternal age more than 35 years, it halves the chances of achieving a pregnancy compared with paternal age less than 25 years. So age has a effect on this fertility also, but it is more noticeable after the age of 50 years, where there will be adverse outcomes in the offsprings like either miscarriages or anomalies. So basically the age of semen donors is limited to 40 to 45 years in some countries. Obesity and weight loss. So obese men, they are more likely to be oligozoospermic or azoospermic compared with men who have normal BMI. Paternal obesity is also negatively affect the assisted reproduction outcomes. But whether the weight loss, this improves the seminal parameters, that is unknown, because sometimes it can be improved, there may be no change, or there may be deterioration also. So whether this weight loss improves the semen parameter or not, that is not known. Regarding diet, as you know, diet consisting, which is a healthy diet, that is vegetables, fruits, fish, poultry, cereals, and low-fat dairy products, it is associated with sperm quality, which is positively associated. So it improvement, there occurs improvement in sperm quality. While processed meat, full-fat dairy products, alcohol, coffee, sugar sweetened beverages, these are associated with poor semen quality parameters and lower fecundity rates. But the thing is whether this supplement, so some reviews and meta-analysis, they have found that the supplement of this omega-3 fatty acids, selenium, zinc, or coenzyme Q10, so whether this they have shown some favorable effects, but the result should be cautiously interpreted because of there is limited sample size and considerable inter-study heterogeneity. So just we can't recommend this prescription of these products for this improvement in semen quality. Then regarding vitamin and antioxidants. So oxidative stress is well known for this sperm deterioration. So it affects the cell membrane, impairs sperm motility, and reduces the ability to fertilize the oocyte. Also, it causes sperm DNA damage. Antioxidant, they protect the cells from oxidative stress, but again the evidence from this antioxidant trial is low quality. So further evidence is required before prescribing this antioxidant. Now cigarette smoking and vaping. So what cigarette smoking, it is associated with again reduced sperm count, motility and morphology, and also it causes decline in sperm quality both in fertile and infertile male. But the effect is higher in infertile male, and oligospermia is also more common in smokers. Also, when they quit smoking, when the smokers quit smoking, every additional year of smoking cessation is associated with reduced risk of treatment failure by 4%. Okay, so miscarriage rate is decreased with every additional year of smoking cessation. Now, what do you mean by vaping? So, vaping is a use of electronic cigarettes. So, electronic cigarettes usually they are viewed as less harmful, but still animal studies shows that they have detrimental effects on the sperm quality. Alcohol consumption, it is also associated with lower semen volume, but it has variable and dose dependent effect on other semen parameters. While habitual alcohol consumption, it is associated with reduced semen quality and changes in reproductive hormones. Also, semen volume, sperm count, motility, and normal sperms, these are all significantly decreased where there is heavy and chronic alcohol consumption. But there is no evidence for negative effect on occasional alcohol intake. So for habitual alcohol or heavy alcohol consumption, the sperm quality is decreased, but occasional alcohol consumption has no effect on the sperm quality. Now, caffeine and cola containing beverages, these also have negative effect on semen volume, count and concentration. Also, it is associated with sperm aneuploidy and DNA breaks, but not with other markers of DNA damage. Stress again, it lowers sperm concentration and progressive motility. Also, it increases fraction of sperms with abnormal morphology. It is because of, usually the mechanism here is suppression of testosterone because of raised steroid levels. So it is a basically hormonal suppression because of raised steroid levels. But the antidepressant which are used to treat this stress or depression, they have negative effect on sexual function and semen quality also. So whenever the stress or other psychological disorders are as a cause of this deleterious semen quality, so their non-pharmacological treatment is more beneficial, like cognitive behavioral therapy, psychotherapy, and counseling and support. So non-pharmacological therapy should be instituted for this stress-associated infertility. Sleep duration, it is again associated with normal testis size in healthy young men. And testosterone secretion, it follows the diurnal variation. So rise in testosterone, it coincides with REM sleep, and it is not coincides with melatonin secretion, okay, but it coincides with REM sleep. Also, prolactin secretion, it increases during sleep, so they are sleep dependent. But again, pharmacotherapy, it becomes dose dependent, and again, there will be tolerance, rebound, insomnia. So it should not be recommended for a infertility treatment. So hypnotics, these are not used for this male infertility treatment for sleep disorders. Now regarding anabolic steroids. So this anabolic steroids, because azoospermia, by interfering with HPG axis, hypothalamo-pituitary gonadal axis, they also cause this sexual dysfunction by causing loss of libido and erectile dysfunction secondary to low testosterone level. So there will be also impaired sperm production and sexual dysfunction. Both will be there because of this anabolic steroids. But here, this is again one condition where you can manage this infertility just by cessation of this anabolic steroids. Just the stopping treatment by this anabolic steroids, the semen parameters will be reversed. So they will recover spontaneously within 4 to 12 months after the discontinuation of this anabolic steroids. And also you can administer SCG or HMG. Okay, so when there is hypogonadal, because of this steroids, there will be gonadotropin secretion will be less. So in that case, you can also give SCG or HMG for this treatment. But it is shown that there will be some persistent alteration in semen parameters even after cessation of the steroid use. So it is important that they should be immediately stopped, and also steroid-free dietary supplements, they may also contain trace of hormone. So it should be emphasized on the patient that not to take any dietary supplements, because some dietary supplements, steroid dietary supplements, also may have some traces of hormones. Now, this is in the previous talk, they have given in detail regarding, just why I have mentioned here is, I have already told in the table only in causes, but basically for hormonal evaluation, okay, because it comes in the your question paper, they will give you the hormone levels, and according to that, you have to identify the cause. So for that, just I have taken this. So in case of pretesticular, so it is a hypogonadic hypogonadism, and it is a rare and less than 1% of male infertility problems. Basically, here the levels of FSH, LH, and testosterone all are reduced. Okay, so remember that in pretesticular or hypogonadotropic hypogonadism, FSH will be decreased, LH will be decreased, testosterone will be less, and also volume of the here volume of the testis is not that much important, but definitely that you should remember that all three volumes will be reduced. It can be congenital or acquired, and as I told you, hypothalamic causes, these are Kalman's, and pituitary causes, they will be tumors, radiation therapy, or surgery. Now, testicular causes, it is known as hypergonadotropic hypogonadism. So it is a testicular failure, and there will be elevated LH and FSH level. Sometimes what happens, there will be LH and testosterone levels might be normal, but there will be only raised FSH. So this is the routinely comes in the question. So FSH is raised, but testosterone and LH is normal. So usually you will be in confusion whether to call it as testicular or not. So, but it comes in the testicular failure only. Okay, and the causes will be bilateral cryptorchidism, genetic disorder, systemic diseases, radiotherapy, or chemotherapy. So sometimes only FSH will be elevated, and because it is because of isolated spermatogenic failure without any Leydig cell damage. Okay. But here, in case of testicular failure, it is idiopathic. 66%. The most common cause for testicular failure is idiopathic. And here the testis size will be reduced and FSH levels will be raised. So this is the main diagnostic feature of testicular failure. Am I audible? Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. Then regarding varicocele, so varicocele, it is a collection of dilated refluxing veins in spermatic cord. The incidence is 11.7% with normal semen and 25% with abnormal semen parameters. But here basically whether this varicocele is responsible for infertility or not, it is not yet proven. So according to NICE guidelines, just remember regarding varicocele that surgery should not be offered for varicocele for treatment of infertility. Okay, so that is the main important thing that you should remember regarding varicocele. No surgery is advised according to NICE. Then regarding post-testicular failure, it is mostly obstructive. So obstruction excluding vasectomy, it accounts for 41% causes of azoospermia. So other than vasectomy, obstruction is the main cause for this azoospermia, and it is 41%. Incidence is 41%. Here, the hormonal levels will be normal FSH, normal testicular volume, normal testosterone. So all hormones will be normal, and evidence of complete spermatogenesis. So testicular biopsy will be also normal. So here, when the testicular biopsy is normal, or hormone levels normal, testicular size normal. So here the cause is post-testicular, and it is a trauma, vasectomy, infection, or bilateral absence of vas deferens. Now, whenever you are going to assess for a patient of male infertility, basically it should be on the basis of history and examination. So in history, you have to take history regarding recent diseases like pyrexia, illness, other systemic illnesses, genetic disorders. Surgical history like undescended testes, orchidopexy, hernia repair, any testicular trauma, torsion, any pelvic bladder surgery. Fertility history like previous pregnancies, okay, previous partners, duration of infertility, and previous infertility treatment. Sexual history, you have to ask regarding erection and ejaculation problems and frequency of intercourse. Medications which are responsible for this abnormal semen parameters, these are nitrofurantoin, cimetidine, sulfasalazine, spironolactone, alpha blockers, methotrexate, colchicine, amiodarone, antidepressant, phenothiazines, and chemotherapy. So remember these medications. And social history like alcohol, smoking, steroid intake, recreational drugs intake, exposure to radiation, chronic heat exposure, aniline dyes, pesticides, and lead exposure. So all these things you should ask in the history for male infertility. And in the examination, first general examination to see any signs of androgen deficiency, testosterone deficiency like gynecomastia, decreased body hairs. Then height, weight, BMI, blood pressure should be recorded. Scrotum should be palpated while the patient is in standing position. So testicular size, consistency, testicular volume, vas deferens should be palpated. And if undescended testis is diagnosed, the patient should be referred for urologist for further management. Then epididymis should be palpated for any presence of varicocele. Penile prostatic abnormality should be noted. Rectal examination to be done to see the prostate abnormalities or seminal vesicle enlargement. So this is regarding the examination, physical examination of the patient. And then coming to the investigations, first and foremost thing will be semen analysis. So it is the initial laboratory evaluation of the male infertility. Abstinence period required is of 72 hours. Single semen analysis is usually sufficient, but when an abnormality is detected, repeat semen analysis should be done after 3 months, or it should be done immediately if initial test shows azoospermia. This is again a repeatedly asked question, remember well. So semen analysis, if there is mild abnormality, mild to moderate abnormality on semen parameter, it should be repeated after 3 months. But whenever there is severe oligospermia or azoospermia, it should be repeated immediately. The main with risk factors in the history or abnormal semen parameters, they should be referred to the male reproductive specialist for further evaluation. And this is the WHO parameters for this normal semen analysis. So this you should always remember. So semen volume 1.5 ml, concentration per ml, it is 15 million sperms per ml. Total count should be 39 millions per ejaculate. Total motility should be 40%. Of that, progressive motility should be at least 32%. Normal form should be 4%. And vitality, that means life of sperm, should be of 58%. Okay, so these are the normal semen parameters of the WHO 2010. Okay, after that, they have not revised the criteria yet. Now, endocrine test. When you should do endocrine test? When the semen count is less than 5 million. 5 million per ml, then only you have to do endocrine test. And which endocrine test? FSH, LH, testosterone, and prolactin. Okay. So, as I told you, low testosterone with high FSH, LH, it is testicular failure. Low testosterone, low FSH, low LH, it is a hypogonadotropic hypogonadism. While azoospermia with normal hormone levels, it is a obstructive or post-testicular cause. So this is the basic thing that you should know regarding this hormone test. And other indications for endocrinological testing is impaired sexual function and hypothyroidism or hyperthyroidism. Now, the role of imaging. So scrotal ultrasound if you are suspecting any testicular tumor or varicocele. And absent vas is detected. If the absent vas is there, then renal ultrasound should be done because 30% patient of absent vas, they have a coinciding renal abnormality. Then testicular biopsy, it should be done in severe oligospermia or azoospermia patients. Okay. And also to see whether you can do ICSI for that, or that is surgical sperm retrieval can be done or not. So biopsy can be done by open or percutaneous needle aspiration. And on the biopsy, what are the findings that you can find is, so it can be normal, that is appropriate number of cells and complete spermatogenesis. Hypospermatogenesis means all cells will be present, but the cell numbers will be reduced. Maturation arrest means failure of spermatogenesis beyond a certain stage. So it can be early maturation arrest or late maturation arrest. And Sertoli cell only syndrome. So there will be no germ cells. So these are the findings you can get on the biopsy, and depending upon that, it is 20 ml. Normal testis volume in adults in 20 is 20. It is there in this PPT. I think I forgot to tell you one.
Ma'am, thank you,
Mean
ma'am.
volume of 20 ml. Okay, so it is normal. Okay, now the test of sperm DNA fragmentation. This is the basic thing which is included in this new talk. Okay, so sperm DNA fragmentation, whether it is to be done or not. So they have given in detail regarding this specific DNA fragmentation and other tests, and regarding the genetic test. So sperm is normal semen analysis is an essential part. It is the first line workup, but its diagnostic accuracy is limited because of lack of adequate discriminating power, and it does not predict. So normal semen analysis or abnormal semen analysis, it does not predict any ART outcomes. So in that case, sperm fragmentation test can be done, which is known as SDF test. So it can be done by sperm chromatin structure assay, sperm chromatin dispersion assay, terminal deoxynucleotide transferase mediated deoxyuridine triphosphate nickane labeling, which is called as TUNEL, and COMET, that is single cell gel electrophoresis assay. So you should not remember all these tests, but yes, sperm DNA fragmentation tests are there, but still now the evidence support that there is a association between high sperm DNA fragmentation and poor reproductive outcomes are there, but it cannot predict the ART outcomes. Okay, so SDF and SDF can predict outcomes in case of natural conception and IUI, but SDF cannot predict the outcomes regarding the ART techniques. Also, again, you cannot do this sperm DNA fragmentation test routinely, because basically for patients undergoing ART, it will not predict the outcomes of this pregnancy, and then there is no treatment for this high sperm DNA fragmentation. Okay, so there is no treatment which has proven to be effective in case of high DNA fragmentation. So it should not be done routinely. Only thing what they have proposed is surgically retrieved sperms. Okay, they will pass the there will be epididymal transit will be less, or it will be there will be no epididymal transit if you retrieve the sperms from the testes. So what will happen? It will minimal exposure to the reactive oxygen species. So in that case, it will be a better option, but still it is not yet proven foolproof approach that you can do for each and every patient which is having high DNA fragmentation. So this approach should be reserved for those who have previous ART failures, and the measures to correct underlying factors causing sperm DNA damage have failed. That means if lifestyle factors are not to be corrected and there are frequent previous ART failures, then you can go for this surgical retrieval of sperm for the ART outcome. Okay. Then what are the techniques for this surgical sperm retrieval? So from testis. Now remember this, it is from this testis and from epididymis. So from testis, surgical retrieval can be done by TSA, that is testicular sperm aspiration, TACI, that is testicular sperm extraction, and microsurgical TACI, that is micro-TACI. And epididymal aspiration is MESA, that is microsurgical epididymal sperm aspiration, percutaneous epididymal sperm aspiration. So MESA and TACI is for epididymal, and TACI, TACI, these are for the testicular sperm aspiration. The previous slide, okay. So this slide basically it shows, see, sperm DNA fragmentation, it is not recommended for routine test, okay, who are undergoing IVF or ART treatments. But, and why it is not recommended? Because there is no proven treatment for this SDF. Only thing what they have proposed is, because when the sperms are surgically retrieved from the testes, there will be no epididymal transit. Okay? And because of that, there will be less exposure to the reactive oxygen species. So it will avoid the sperm DNA fragmentation, and these sperms can be used for the ICSI. But again, data is less, so it is not recommended for all. Surgical retrieval to avoid the DNA fragmentation is not recommended for all patients. But only thing, it can be done for previous ART failures and when the measures to correct. So this lifestyle intervention are not able to correct this DNA fragmentation. Got it? Now, what are the new developments in sperm selections in case of ART? So, usually in ART, so for IVF or ICSI, the sperm collection is done by, or sperm selection is done by this density gradient or swim up technique, and both techniques, they are equivalent. So, no technique is superior to the other. Okay, but these are the basic two techniques which are used for this IVF or ICSI for the sperm selection. Now, what are the new selection procedures? So, one is mesome. So, mesome means motile sperm organelle morphology evaluation. What it is? So, it is very high powered observation. So, high powered means 6,600 to 30,000 times it is magnified, that sperm is magnified, and the sperm which is magnified is an unstained sperm. So all organelles, they are assessed like acrosome, post-acrosomal lamina, neck, tail, mitochondria, and nucleus. So after observing this under high power, the sperm selection is done and then ICSI is done. ICSI is done with that sperm. It is known as IMSI, that is intracytoplasmic morphologically selected sperm. So this IMSI is an option for a good sperm selection, but it has not shown to increase the treatment success and clinical use remain unclear. So IMSI is a one new technique for the sperm selection. Other techniques is physiological ICSI, which is known as PICSI. So it involves selection of mature sperm which is bound to hyaluronic acid microdot for oocyte injection. So it is a physiological. So it has a affinity for this hyaluronic acid, normal sperm. So you have to see which sperm is attached immediately for this hyaluronic acid. But it is again not recommended for routine clinical care. Another thing is HOS test, that is hypoosmotic swelling test. So this HOS test is why it is done where the motility is very poor. How you are going to see for the vitality of sperm, whether the sperm is live or not. So all motile sperms, these are live sperms, correct? So if the motility is normal, that means the sperms are vital only. But if the motility is very poor, then you have to see which sperms are live and which sperms are dead. So you have to see for vitality. So in that case, this hypoosmotic swelling test is useful. So in that case, what happens when the spermatozoa, these are live, when the sperms are live, if they are placed in hypoosmotic media, their tail will swell. Okay, and this is a reversible change. Okay, so this is a reversible change and it will not damage or kill the sperm. So this HOS test, it can successfully select the live sperms when the motility is very poor. So this HOS test can be used for the selection of sperm where the motility is very poor. Yes, this is a recent talk. This is a 2020 talk where these techniques are discussed. So this HOS test is successfully used to identify viable sperms for the ICSI. Then other which are new developments. So one is microfluidic system, then 5-phosphodiesterase inhibitor media, magnetic activated cell sorting, or zeta potential sperms. So basically these cells, these are new techniques, but these are not routinely used and these are not all are very proven benefits. So just remember the names, but no need to remember the detailed techniques. Now, what is the role of genetic testing in case of male infertility? So till now I told about the first is regarding DNA fragmentation and next regarding how to do sperm selection for this ART. Now, when the genetic testing is required. So why genetic testing is done for male infertility? First, to see if the male partner is having any condition that can be passed to the offspring, or if the which male partners who are having azoospermia, they can benefit from surgical sperm retrieval procedures. So it is usually done for azoospermic and severe oligospermic males. And what are the genetic tests which are routinely done is karyotyping, Y chromosome microdeletion assays, and cystic fibrosis mutation analysis in case of congenital bilateral absence of vas deferens. So in case of congenital bilateral vas absence, you have to do cystic fibrosis mutation test. Otherwise, you have to do karyotype or Y chromosomal deletion analysis. Again, what is the new thing here is, so in case of congenital bilateral absence of vas deferens, they have found out another gene which is known as adhesion G protein coupled receptor gene. So this is also can be considered in case of congenital bilateral absence of vas deferens disease. Okay, but finally, whenever you do this genetic test, they are only able to diagnose only 20% of men with the infertility. So these are only found in 20% with azoospermia cases, and otherwise all 80% they are idiopathic. Okay. Now, whenever you do karyotype, the most common aneuploidy which is found is Klinefelter syndrome, that is 47XXY, which is found in 11% of azoospermic males. Other chromosomal abnormalities which are found is 46XX syndrome, or balanced or reversed unbalanced translocation, invergent deletions, and insertions. However, this karyotypic testing, it has limited resolution and it cannot always provide details regarding specific regions on the chromosomes. Okay, so one such region is known as AZF region. It is located on Y chromosome. So this deletion is observed is almost 7% of azoospermic and 2.9% of oligospermic. So for such detailed genetic analysis, you require higher test than karyotype. So now there is trials are going on regarding this novel diagnostic test, which can explain this other 80% of this idiopathic azoospermic cases. Okay, so this test includes spermatozoa genetic testing and epigenetic test. So this genetic testings for sperms, they include usually DNA fragmentation testing, chromosomal aneuploidy analysis, and the FISH technology. So right now these are the things which are done, but this epigenetic testing and specialized genetic testing, these are under the trials which can identify the other 80% of male factor infertility, that is azoospermia cases. They may find out some causes and whether they are treatable or not. So this is basically regarding this new male infertility talk. And as I told you, there are no questions, no strategy questions from this talk has come yet. So I have not included any questions. So this is regarding both. So I have combined both male infertility talks. So it is a compiled thing. You no need to read anything extra for this. This talk is October 2020. Okay, percentage of idiopathic infertility. According to 2013 talk, it is 66%. Okay, and according to new, what they are telling in azoospermic males, azoospermia or severe oligospermia, it is 20% in 20% of azoospermia and oligospermia causes identified, while 80% of azoospermic patient causes not identified. Okay, so there it is 80% and 20%, while 66% of this thing, it is according to the old talk. So according to new talk, it is 80%. Okay, and 50% of patients, those are responsible for the total infertility cases. So male factor is responsible for 50% of the cases. Got anything, any other doubt regarding this percentage?
Hi, Dr. Mridula, ma'am.
Yes, Ankita. Yeah.
Ma'am, should we read the October 2020 talk, because like paper are set already 6 months back?
I know, but right now papers are not set 6 months back. Correct? Because of this corona, this exam was only in September, last exam. That's why otherwise I would have
Yes,
not
ma'am.
taken the talk right now. But this time I don't know what can be asked, because this now I don't think they have just set the paper right now only, okay, for your January exam, because till now dates were not decided, nothing was decided. Correct? So we don't know
Okay,
exactly.
ma'am. So we have to read
So
October 2020 talk, ma'am.
yeah. Better to read October 2020 also. Otherwise, yes, for
Okay, thank.
January people, day is required. But this time we don't know. Everything is exception. Okay. Yeah.
Okay, thank you, ma'am. Your efforts are really appreciable, ma'am. You're doing great. Thank
Thank
you,
you.
ma'am. Thank you for helping
Thank
us.
you. Thank you, dear. Bye. Bye.